Okay. All right. Good afternoon. I figured that we should get started given that somebody started the recording. And thank you for the opportunity to present. My name is Jonathan Sussman. I'm a radiation oncologist and health services researcher here at McMaster University in Hamilton. And we're doing a bit of a tag team today. So sitting here on my left is Dr. Dale Rainbridge. Daryl has a PhD, again, from the Health Research Methodology program here and works as a senior research coordinator in Hamilton. And what we were planning to do today, or what we'd like to do, is just share with you some work that we've been doing, applied research actually, with a new program that sort of started its life more in serious illness, perhaps palliative care world, but it's moving up in the care trajectory, and it was a fairly unique opportunity for us, and we thought that we'd share it to see what your thoughts were. So we're going to present on the family-centered care in adult oncology, the implementation and impact of a child life specialist program. So nearly 1 in 4 adult oncology patients have at least one minor child at home. And children of cancer patients may experience significant emotional and physical symptoms, similar obviously to the adult cancer patients who we all are used to seeing. Often these issues are not assessed or addressed by the adult cancer system, and certainly that was the case here. There is pediatric research which demonstrates that support can clearly mitigate these effects. And specific support for children is often delivered, certainly in Canadian hospitals and institutions, by the child life support professionals within a pediatric care program. These are not typically linked to adult oncology care. And what happened is that there was a gap that was identified here through our psychosocial oncology office in terms of providing full family support. And the question was, could we bring a child life specialist into the team, and what would that look like? So child life specialists are specialist psychosocial health professionals, and they help children and youth understand and cope better with the stresses of illness, medical treatment, and different abilities through a developmentally appropriate education and therapeutic plans. So there's special training for individuals who hold these roles. They also help guide parents through supporting children and facing the stressors at home. And the interventions that are delivered basically fall into 5 different sort of categories. There's psychoeducational, ongoing guidance and support. A lot of what some of us would see as the medical play, where play is used with children to help support understanding of an illness, as well as therapeutic play to help process emotions, and then in some instances, legacy building as well. And the child life service, again, would line up very nicely with what we try to achieve in oncology, in that it's a family-centered collaboration, but goes outside of the institution and basically connects the health institution to the family and the home, and through to other institutions in the community, as well as schools. So really what this came from was from a gap and a particular interest that there was in Hamilton, where the senior leadership at the hospital asked about whether there was a way to provide better support for children of adult cancer patients. And that's really where this program came into being. So the goal was to develop a child life specialist program with links into adult oncology. And this was a new build because really, from what our understanding was, there wasn't really anything existing like this anywhere else, certainly nothing in the literature. So it started with some ad hoc consultations, trying to collect some anecdotal evidence, trying to do a literature review, which didn't really find very much. And then ultimately developing partnerships between the McMaster Children's Hospital, that's MCH, and our cancer center, the Juravinski Hospital Cancer Clinic. And to just give you a bit of a geographic understanding, Hamilton is pretty geographically spread between health institutions, and the Children's Hospital is actually 4 kilometers away from the cancer center. So there were going to have to be some logistical issues put in place to help sort through the logistics of this. At that point, the Hamilton Health Sciences Foundation stepped in with a clear mandate of trying to help develop these support programs. And like the idea of trying to pilot an innovative care program, and alongside try to collect some useful information and data. And it was the program evaluation really that Daryl's going to tell you about, which really really sort of consolidated what was happening here and had a very nice outcome, because again, as we know, we talk about Canada or Ontario specifically as the land of many pilots. And there's always a struggle to implementation, but that's not how this story goes, thankfully. So we had to start to ask what happens when we try to embed a child life support worker in an adult psychosocial oncology program. And that required identification of significant stakeholders. So although we didn't have, I guess, what would be considered a completely formulated program at the time, we still had to take the steps that I guess some of you would be more expert in me in describing around sort of an implementation science approach through the engagement, once the need has been identified and when we've seen the opportunity. So you can see that there were extensive consultations and discussions that had to take place to try to set things up so that the child life service worker or position could become embedded into our psychosocial oncology program.
So the Child Life Specialist program was initiated in November 2019, and it consisted of a single position that was 0.6 FTE. So we're going to hear from two of the Child Life Specialist workers that were from this program. First, we're going to hear from Heather, and she was a CLS when the program was started. She was really instrumental in raising awareness within the Cancer Center and the hospital of this program, as well as growing the program. And this will give you an idea of their roles. Later on, we're going to hear from Bridget, and she is the current Child Life Specialist.
Of the Child Life program at Jurvinski. And so this will kind of highlight a little bit about where we started, and then throughout the presentation, you're going to see where we are now. So this is April 2020, early days of the program. It is an ICU weekend consult. So when we started the program, we provided care on an on-call basis, as well as the 3 days a week during the regular work week. And we did this because it was a pilot program and we wanted to demonstrate the need. So this was one of those weekend consults. It's a 39-year-old male with metastatic pancreatic cancer that was diagnosed in October of 2019. So about 7 months since diagnosis. And he has 2 children, ages 7 and 10. And at this point, all the children have been told is that dad is sick with no prognosis explained, and the family has chosen not to use the word cancer or explain where things are at with treatment and life expectancy. So at this point, the patient is intubated with plans for withdrawal the next day, and the child life consult was initiated by the ICU team. And the patient's wife is asking for support for explaining end of life to their children. So that is when I came in. This audience is well versed in the barriers that presented themselves during the pandemic. One thing we really want to highlight is, with all of the restrictions that were implemented for safety during this time, children and how they are affected by those barriers in the adult setting was truly highlighted at Jurvinski. We had a lot of kids whose parents were admitted for long periods of time at end of life, which this case is highlighting, with no options for visiting, because nobody under the age of 18 was allowed to come into the hospital at that point. And also we didn't even have like the masking available. So in this case, I needed to go to the director to get approval to bring these 2 children in to say goodbye to their father and to be able to provide the child life interventions that we would in this case. So it went through the director, had approval for one visit with the children. It had to be after hours when there were no other visitors that were visiting at that time. And also I had to go to McMaster to get pediatric masks so that we could appropriately provide PPE to children that was appropriate for their size of their face. And I mean, this is definitely one of those situations that highlights the pandemic barriers, but it also highlights the fact that these restrictions in terms of the care that can be provided to children is something that isn't just for the pandemic. A lot of times kids are often forgotten in the adult hospital setting when they are so impacted by the admission of the patient. So it highlights the family-centered care approach that really is needed here in these cases. When meeting a family at this point, it definitely is not ideal because basically in one session, I needed to accomplish all that we would have wanted to provide to this family, which is building trust and rapport with these kids, helping to explain their dad's condition to them and what pancreatic cancer means, what the metastases, what that looks like, what treatment was already attempted, why that treatment isn't working, and then explaining the end of life and preparation for seeing their father as well. Trying to do all of those pieces in one visit is not ideal. And it was the case in a lot of the consults in the early days of the program. With this family, with these children, I started out by doing a diagnosis explanation, trying to explain what pancreatic cancer is using diagrams, because for children, it's important that we meet them where they're at developmentally. So using different diagrams, using sometimes scans, and also being sure that they were going to be prepared for what their dad looked like. In this case, these kids had not seen their father for a number of weeks. And the last time they saw him, he wasn't intubated. He didn't have lines coming out everywhere. And he was able to talk and be able to interact with them. So there was a lot of preparation that had to go into that. Also, I had to do some liaising with the nursing team to try to limit how many alarms were going off during the visit as well, to be sure that that visit was going to be as meaningful and positive as possible in this kind of circumstance. So after doing all of the explanation and bringing the children in to see their dad, it was really important that we spend a lot of time making memories with this family. And through that, we do these legacy activities where we actually do prints of the hands. So obviously the patient at this time could not interact with us. So I would do the prints for them and be able to really engage the child in interacting with their parent in a way that they can. So these kids really enjoyed taking the wipes and wiping it on their dad's hand and talking about what they think dad is feeling at this time, and explaining to them that he can actually feel that, and making sure that they felt that their interactions with him were important, considering this was going to be the last time that they ever saw their dad. And so we did, handprints. They made some beautiful pictures, as you can see on the side there on the left, as well as a family tree. And we do a lot of talking about how even after somebody dies, it doesn't mean that their family isn't complete. They still have a dad. Their dad just is not here with them anymore. So every member of the family got a different color for their fingerprint, and we made a family tree. So the extent of the legacy activities that were offered were one-time go, basically. If we have more time, we have a lot more options in terms of what we can offer families, as we'll see later in the presentation. And then also at this point, there wasn't a lot of availability for doing grief or bereavement follow-up afterwards. So the follow-up that happened was basically providing the mother with grief and bereavement support programs in the community for her to access for her children. And so that was the early days. There were a lot of consults like this that were the last moments type thing where kids needed to come in and say goodbye to their parent. And I was very grateful that we got the approval to do that in the pandemic, but it took a lot of background work for sure.
So with the initiation of the CLS pilot program, we did a concurrent mixed methods study. That was the implementation feasibility study. And we studied a prospective cohort of cancer patients. We used a well-known feasibility framework to frame the study that features 7 different domains for consideration. We collected both quantitative and qualitative data. And again, it's important to highlight that this happened with the start of the COVID pandemic. We collected data from a number of different sources. We collected data from patients, from the families. We collected clinical encounter data. Basically, the services that were provided by the CLS. We conducted adult interviews and child interviews, and we conducted focus groups with both social workers that had referred to the program, but also members of the psycho support team. And finally, we did a narrative inquiry, which I'll go into in a little bit. So our study and the pilot phase of the CLS program ran from November 2019 for 10 months to October 2020. And during that time, 98 patients and families were referred to the program, and 91 decided to use the CLS services. 2/3 of these cancer patients were female, and just over half were between the ages of 40 to 49 years of age. About a quarter had breast cancer, and about 3/4 had stage 4 disease. However, less than half were undergoing treatment for palliative intent. Almost half the families had 2 kids at home. 2/3 were the family situation was the cancer patient was co-parenting with the birth parent, but we found lots of great diversity in the types of cases and the family scenarios, including single parents, mixed families, and even cancer patients with a child adult with developmental considerations. So just before referral to the CLS, the cancer patients, half of them had scored positive on the ESAS for anxiety, and about a third scored positive for depression. And what that means that they scored 4 or higher on that 10-point scale. So all the referrals came from within the cancer center or the hospital, and these were managed by the psycho support team. About 2/3 came from social work, either inpatient or outpatient social work. And about 20% came from medical or radiation oncology. Over here, you can see the different disease sites represented. So we had a diversity of types of cancer. We had almost 20%, which were these hematological cancers, and these may have been stage 4, but being cared for with curative intent. In terms of the encounter data, over those 10 months, there were 257 clinical encounters. 282 of these were remote or virtual, including by phone and by email. 75 were in person. Even though COVID was on it, was creating restrictions for access to the cancer center and hospital, there were 75 in-person interactions. In terms of these in-person encounters, they often included multiple family members, but most of them included the cancer patient, but also co-parents, the children, and other family members. These in-person encounters largely occurred at the cancer center or hospital, but also the home, the McMaster Children's Hospital, in residential hospice, and other areas. So for these in-person encounters, the average time for the spent was about 2 hours, with about 36 minutes of preparation and 90 minutes of direct interaction. So usually these CLS interventions had multiple purposes and goals. Most often, it was helping the parent or patient speak to their children about their disease and providing guidance for that. Also providing resources, diagnostic teaching for the parents and the children, and end-of-life support, among other things. So although this was a feasibility study, we did try to collect some patient-reported outcomes, although these are, of course, limited. We plan to have patients complete surveys pre and 2 months after the intervention. These were the cancer patients only. We did not collect data from co-parents or from children. We weren't able to find any CLS-specific tools to measure this program, but we did find some applicable ones, this being the Hospital Anxiety and Depression Scale, the Parenting Concerns Questionnaire, Cancer-Related Parental Self-Efficacy Scale, and we also created a healthcare satisfaction survey, which was one item that was asked after the program. So to preface these data, there are a number of limitations to mention. So patients were approached prior to referral to the CLS program. However, we were not able to include patients in the survey if it was deemed that they had an urgent need. So we missed a lot of patients because of that. Considering that, there were 29 cancer patients that were eligible to do the survey, and 23 did complete the survey, and we were able to follow up with 16 of those. And again, this was a single cohort study. We didn't have any control data. So in terms of the ratings of healthcare satisfactions, most patients felt that the CLS service was helpful to them, and most felt that it was helpful to their family, then their children, and met their needs. As for our scales, our 3 scales that we measured, they all demonstrated improvements in issues, but these findings were not statistically significant. Again, we had a very small sample size. But we did find some trends in terms of improvement in anxiety and also emotional impact on this parenting concerns questionnaire. As I mentioned, we collected qualitative data. So we did 10 interviews with patients. 4 of these patients were being cared with palliative care intent, and 4 interviews with co-parents, and 3 interviews with children. We also did focus groups. We did 1 focus group with members of the psychosocial support team, and 1 focus group with the inpatient social workers. So in our analysis, there were a number of different themes that emerged from each group, but also a number of overarching themes. And these being that it was felt that this program added value, that it was well integrated into the cancer center services, that it provided family-centered care. Oops. Another thing that emerged was just having to create awareness, and so that people being patients and providers better understood what this service was. And of course, the impact of the pandemic. In terms of areas for development or improvement, the patients indicated that they would have liked to have accessed this service earlier, and they wanted it more. So they wanted more time with the CLS. We didn't find much difference between whether or not the patient, the intent of their care was curative or palliative. I'm just going to read a couple quotes from parents, children, and providers. So the first one: as a teacher, I know about child development, but this is more personal. It was hard to figure out how we even start. She helped me go through each of the things that I want to say to my son, giving really good feedback to help me start that conversation. And from a child, we learned all about my mom's chemo and surgery. The activities helped me understand more. The CLS explained slower to my younger sister and used Barbie dolls to help her understand. And finally, from a provider, Child Life has these magical toolkits of things that kids can understand. They can break something so complicated down to something that is so easy to understand. So finally, we did this narrative inquiry. And that is really to look in depth at the challenges and strategies to working for child life specialists and working in adult oncology. So we interviewed 4 child life specialists across Ontario who work in adult oncology. And actually, these were multiple interviews. And some of the themes that emerged largely related to some of the challenges. And this was, again, raising awareness and education about the role. The fact that many parents are apprehensive about exposing their child to, about using the program and exposing their child to the child life specialist service. That there are some systemic barriers, such as late referrals to the service. And also a lack of formal transition options, particularly after the death of the patients, for bereavement services. So 2 quotes that really stood out were, first of all, it's a bit of a dance. And what this refers to is the child life specialist having to balance what they feel is best for the children with the wishes of the parent. And the wishes of the parent is always a priority in determining that the type of service that the child life specialist delivers, but that can be a bit of a challenge sometimes. And the second quote is that there is so much more support we could have provided. And again, that speaks to getting these late referrals, sometimes one-time interactions, where it was felt that if they had been able to engage the parent and child further upstream, a lot more support could have been provided. So in terms of research dissemination, we have we've written a number of qualitative and quantitative papers, some published, some in press, and some underway. And we've presented at a few international conferences, including ASCO. So now we're going to hear from Bridget, and she is the current child life specialist, about a recent case.
To give a bit of contrast to the case that Heather provided in those early days of the program, I'm going to share a case example from 3 years later after the role has become a permanent position and continued. We're looking at a 41-year-old male, and he's been diagnosed with a neuroendocrine tumor. This is a new diagnosis. He's still undergoing staging to determine extent of disease and prognosis. So the stage is unknown, but he's been going through several months of testing to reach this diagnosis. And over that time, his vocal cords have been impacted by this tumor. So he's gradually lost the ability to speak. At this point, the plan is for him to be starting chemotherapy urgently. Him and his wife have 2 children. There's an 8-year-old son and a 10-year-old daughter. And, you know, he's entering the oncology world as a patient and facing so much uncertainty and fear and stress for the impact on his life, but also those questions of how do I tell my kids, what do I tell my kids, when and how much, and just that really overwhelming moment. In this example, Child Life was consulted early to help support this patient and his wife with having that language for how to explain things to the kids, for them to understand this treatment that would be starting, and really helping to promote the connection with their dad, especially recognizing what the last few months have been like for this family upon reaching this diagnosis. So Child Life was consulted by the team at the disclosure meeting and was immediately available and prepared with the guidance and resources that this family needed. Because of this early involvement, the first visit was really focused on helping to explain Dad's cancer in a child-friendly manner, similar to part of the intervention that Heather provided, but really with the opportunity to go more in depth. And sometimes we're using scans or we're using, simple age-appropriate images to help the kids understand what has happened so far and what we know right now. We had questions around navigating that unknown prognosis and helping the kids to understand staging and testing that was going and really balancing that hopefulness and honesty. We also talked about Dad's treatment starting and for them to become familiar with the PICC line that he would be having put in and going home with, and how that would impact their relationship and how they engaged with their dad as he continued to go through treatment. When this family unfortunately received the news that his cancer was incurable, again, Child Life was available to support the family with how to share this news with the children in an age-appropriate way, just providing that ongoing coping support, opportunities for emotional expression, opportunities for kids to ask questions and make sure that they were fully understanding, and sometimes revisiting things that, we had spoken about over the last several months and how that related to the things that we were seeing at this point in Dad's journey, and just overall helping them feel included and involved. And that was a really big part of what we had learned from the early days of the program too, was just how important it was for kids to have that ongoing dialogue and ongoing involvement through the cancer journey. And along with Dad's treatment, how that changed their relationship. The dad was really tired going through chemo, and that he wasn't able to engage and do the things that their family had enjoyed doing before all of this. So sometimes we're using tools like books, like the one you can see on the screen here, the invisible string, and doing those therapeutic interventions like feeding that goes along with that story, that really promotes that parent and child attachment, and that we know overall promotes kids coping in the future. So helping, helping this family to have lots of strategies and resources to support the kids throughout the journey. And we were also able to begin talking about legacy work and initiating some memory making activities and experiences at this point as well, as we navigated knowing, the incurable nature of Dad's disease. Several months after Dad had continued to decline, and we were working with the family on some of those, memory making opportunities. We had put together a quilt that had different articles of clothing that were Dad's, that they were able to kind of choose alongside with him. Mom was also working on a memory book project where she had captured different quotes from family members and friends and within their family, and had put together this really beautiful book for the kids to have. Towards end of life, Dad was here at hospital. We were able to do some of that handprint art and fingerprint art, and then it was kind of that transition piece from when Dad went from hospital to hospice, where Child Life was available to help prepare the kids for this new environment and understand what hospice is, understand that this wasn't, the same as a visit to the hospital that Dad had several times over the course of his illness, and really for them to be prepared for his end of life and to be included and involved. So through collaboration with the hospice as well, and ensuring that there was appropriate activities and memory making opportunities for when they visited Dad at the hospice. So in this scenario, when it did come to the end of Dad's life, as difficult and sad as this was, we know that there were no surprises for the children in this situation, and they were prepared and supported all the way through. And it ended up being some beautiful encounters that were able to happen because the kids had been so well supported, and it was a really collaborative effort across the different spaces that, the healthcare spaces that Dad was in. So after Dad's death, Child Life support continued by helping Mom to prepare her kids for what the funeral would look like, what their engagement was. For some kids, they've never been to a funeral before and aren't sure what to expect and what it will look like for them. So helping her and using that play-based approach. Sometimes we'll use things like Play-Doh and we'll create what the funeral environment looks like in that child-friendly way, who would be there, what emotions they could expect to see, and talk about what their involvement looks like. You know, sometimes that's during the planning, if they're helping to choose songs or choose the clothes that dad's wearing or something to go in the casket, and what things would look like during the funeral as well. You know, maybe they have something they'd like to say or a note that they'd like somebody to read on their behalf. So really finding what's most meaningful to each family, and overall just really promoting their connection with their dad through these initial early days of their grief. We also talked about what would happen to his body afterwards, and that he would be buried in a cemetery, and providing that education about what that cemetery is, how they can visit, and kind of what that experience would be like. A really vital piece here too is that connection with the school. Often that transition back to school after a significant loss of a parent for kids can be really challenging. So having that communication with the school about how we can best support these kids as they return, and having a plan in place in terms of what their engagement at school looks like, what extra support that they need, and overall education about how children grieve, and how their grief is different than us as adults. So that really strong connection piece between the home environment and having that child life support and collaboration with the school overall gave the best support that we could for this family going through this time. Overall, you know, this approach of early involvement of child life really gives that initial relief and resources of that support being there, and how it can continue and evolve over an adult's illness journey, and sets the trajectory for how things can be continuous through any ups and downs of treatment and of a diagnosis, and changes in status, and in some cases like this one at end of life. This program has also been recognized as a leading practice through the Health Standards Organization in 2023. And in the same year, it also received an honorable mention in the Innovation Award category. So, you know, we recognize that it's clear that the program is having a significant impact outside of, you know, the hospital walls, and leading the way in the standards of cancer care in Ontario.
So again, something a little bit different, I guess, for the survivorship group. And there might be some questions that individuals will have, but I think that there were some very interesting learnings from this. And it also started to get me thinking about the issue of the fact that even in serious illness, and, you know, when our patients pass away, particularly those with children, they become the survivors of the cancer experience. And being able to provide that support to help them get through, I guess, and hopefully set them up for you know, less difficulty, I guess, during the survivorship period. One of the major things that came out of this is, because we were able to try to put a bit of a program evaluation around this, albeit formative, is that the decision was made by the executive at the Cancer Center and the Pediatrics Hospital to fully fund this program permanently. So we now have a part-time permanent 0.6 PSO support care team member as a CLS, who works 3 days a week as an on-call as well over the weekends, and receives routine referrals with wait times that are actually quite short. The other thing that's happened is we are collecting some data going forward, and maybe be able to share in the future, where in particularly for a young oncology patient population, for example, in breast cancer, we have a specific newly diagnosed young women with breast cancer program, putting this CLS in place to help support the children early on in a curative treatment trajectory is going to be interesting to follow, to see what additional supports and hopefully benefits we can see from that as well. So thank you, most importantly, for your time. Again, a little bit of a different topic and a little bit of a different perspective today, but hopefully you found it interesting, certainly interesting for us in terms of taking taking advantage, I guess, of a confluence of circumstances that led to us being able to bring in this initially pediatrics-based program and specialist into the adult oncology world. But of course, we'd like to thank the patients and their families first and foremost, and then the foundation that funded it, as well as the senior executive leadership here that had the vision to try something like this, because as you know, it was a little bit risky, not knowing how this was going to go, and in particular during COVID. I think the other thing is, despite the fact that you know, our analysis obviously is quite limited, you know, there are going to be all kinds of issues with this kind of a setup, as well as our sample size. It at least allowed us to get some insights into the types of data collection that we might be able to undertake, and think a little bit about the tools that we've used and perhaps refining them as well. I do want to acknowledge that Dave Lasecki was sort of the clinical lead for this. He is a pediatric physician, and then Heather was the initial CLS who helped set this program up. Daryl, who's the coordinator, Bridget and Tracy, a couple of the other CLSs. And then the two other individuals, Georgie was the director of clinical programs here at the Cancer Center, who sort of made this happen in terms of operationalizing it. And at the time, our VP was Ralph Meyer. So happy to take any questions or comments if anyone has them, but really appreciate your attention.